Good afternoon, everyone. I'm Steve Wogen, the Chief Growth Officer at CareCentrix, and I'm pleased to have with me this morning an esteemed panel of experts, Michael Ducharme, Dr. Eric Coleman, and Terry Maxwell, to talk about the opportunities and the critical importance of, as well as some of the challenges with leveraging artificial intelligence, sometimes called big data, machine learning, analytics, and successfully managing patient care in a holistic way. First of all, this year has been a transformational year for all of us at many different levels. But within healthcare, never before have I seen such a focus on reinventing and rethinking care delivery models, transforming care in a way that thinks outside of the traditional boundaries of care settings and acute care, finding new ways to leverage technology, our AI and machine learning models we'll talk about today, with a re-emphasis on whole patient and home-centered care and ways to create more value, improve outcomes, and enhance overall satisfaction with the healthcare experience for every consumer and every patient out there. The hype and the promise of predictive analytics is very real. And when used correctly, there can be tremendous power in its ability to change how we think about healthcare delivery. But technology and analytics in and of themselves should be seen as an enabler. And an enabler to patient-centered care and home-centered care, not as an end in and of itself. If we can get it right and find the balance of technology, analytics, and service, and individual support for the patients that we all care so much about, it can be a force multiplier in improving cost of care, quality of care, and effectively engaging the healthcare consumer and effectively engaging caregivers, and identifying and closing gaps that work for the benefit of the entire healthcare system. Today, our panel is going to take you through their thoughts on how to find this balance and ways to more effectively use kind of analytics and technology in healthcare and to harness that power in patient care transformation. I'm going to help guide the conversation through a series of patient vignettes and some real-world lessons learned. There is a QA function available, so all of you can access Q&A through the chat function. We'll do our best to keep up with the questions that are coming in as a way to address questions in this virtual world. Hopefully soon we'll all be able to have these conversations in person again. I would ask that each of the panelists introduce themselves as we turn the conversation over to you. And with that, let's get started. So Michael Ducharme, you're going to be first up. Michael is a data scientist within CareCentrix. Again, I'd ask that you introduce yourself, but let me start with a question, Michael. There are a plethora of data science programs out there, and so much excitement and buzz in the industry around AI. And one of the things that I think could be a challenge is how you take that data science and combine it with real-world thinking and real-world evidence to create a model that can truly impact patient care and have business relevance. So, Michael, love to get your thoughts on that, but again, first introduce yourself.
Yeah, thank you, Steve. So I'm Michael Ducharme. I'm the Vice President of our Advanced Data Labs at CareCentrix, and I focus on developing AI machine learning models that can improve patient outcomes or improve our operational efficiency. So to your question, yeah, there's a lot of hype and excitement around AI, and really the key is how do you make it actionable? How do you make it impact outcomes? And we found that there are three criteria that we really try to focus on. So, and I'll go through each of them, but it's defining the dependent variable, and that dependent variable is the item in a supervised model that you're trying to predict. So typically it's you're predicting readmissions or length of stay. It's what you're trying to predict. So the first step is defining that variable. The second is coming up with an accuracy measurement. Typically, comparative effectiveness is what we find helps see through any fuzziness. And the third one is always evaluating AI ethics. So I'll go through each. The first one, defining the dependent variable, is important because by the time you translate from the data scientist to the business application, you typically end up with a business definition, like we're trying to predict the optimal length of stay. And the key question there is, how do you define optimal in that variable? So we've seen definitions in the industry where it's the most likely length of stay, or maybe it's you defined it as the most likely length of stay minus 10%. And the answer you're probably looking for that's going to be meaningful is that you looked at length of stay and you defined optimal based on the patient outcomes. And you should list those specific outcomes and make sure that they're clinically relevant. So that's the first step to making it reasonable, is making sure we really understand how the predictive variable is defined. Comparative effectiveness is knowing that we need to go deeper than just looking at a model's accuracy. So if we're predicting readmissions and the model is 85% accurate, that sounds great. But if you have a population where only 15% of members are being readmitted, saying nobody will be readmitted is 85% accurate. So you need to look at accuracy compared to the next best alternative. What's the standard, an industry standard peer-reviewed model? What's the accuracy there? How are clinicians on their own without the benefit of data? How accurate are they? And being able to do some comparative effectiveness to really assess models. And then the third item we look at is AI ethics. One of the advantages of the machine is that there is no bias, but it's trained on historical data. And oftentimes historical data can have built-in biases in there. And you need to think through that use case to make sure that you're not perpetuating it. So for example, if you're a skilled nursing facility and you're trying to optimize the patients in your bed, so you decide to build a model to predict which referrals are actually going to turn into patients that show up, because not every member shows up. And you build a model and it's accurate, and you determine that about 5% of your membership doesn't show up, or they show up and only stay for 1 or 2 days and end up leaving. You could then develop a business case that when one of those members that your model identifies shows up, you end up double booking to optimize the beds that you're using and making sure you're leveraging your entire facility. You then could look after the fact and realize that it's minority patients that are most likely to not show up. And you can now have a business rule that results in you double booking the majority of minority referrals. So even if the model is accurate and it's well defined and the business case makes sense, you then need to look through, are there historical biases that your machine may not be aware of, but is identified and then built into its algorithms? So those are the three things that we focus on at CareCentrix to ensure that our models are actionable, and that when we're evaluating partners and potential vendors, that we look at how they've developed their models as well.
Right. Yeah. So thank you, Michael. So I appreciate the data science perspective. I mean, words like bias and variables and dependent and independent and use case. Let's take it down to a more applied level for those of us that don't have the degrees behind their name. So let's look at social determinants of health as an example. It's a buzzword in the industry. Clearly, it's important. The ability to proactively kind of predict and think about what types of community and social resources we can put around the patient to make sure we're thinking about the care of that individual more holistically and to more effectively manage those needs is something that is critical. Why don't you take the scientific terms and kind of apply that to at a patient level in terms of how we could think about that, or how we should be thinking about it?
Yeah, so it's well known that social determinants of health, or economic determinants, or behavioral determinants all influence patient outcomes and influence clinical outcomes. If you try and imagine a picture around a patient, there are all of these components that contribute, and some are clinical and medical, and some are if they don't have access to food or cars, or their education and financial. Each of these pieces build and interact with each other to impact that patient's specific risks and that patient's specific needs. And we are looking at, is something actionable? And to bring it down to the actionable level, the data needs to be accurate at the patient level. And the challenge is that if you are defining a social determinant based on a zip code or a block level, then it's by definition not accurate at the individual level. And if it's not accurate at the individual level, then it's not a lever that you're going to be able to effectively pull. So, for example, in the industry, we typically hear about food deserts. I'll talk about food swamps just because it's slightly newer. But a food desert, as you all know, is a community where there's very little access to grocery stores and to healthy foods. A food swamp is kind of like the opposite. There's plenty of food options, but most of them are unhealthy. It's convenience stores and liquor stores and fast food. And so if you have 100 patients that live in a zip code that's defined as a food swamp, you're going to develop models that identify, that encourage you to interact and try and improve the food access for these members. But typically what happens is that every individual responds to community factors differently, which means that if you assume everyone in a food swamp has some food issue, you're going to be incorrect the majority of the time. So what we are trying to do, and I think where the healthcare industry needs to move to, is focusing and trying to figure out how each individual is reacting to community factors differently, and making sure that we're measuring accuracy at the individual patient level. And that's what allows us to truly come up with the descriptions around a patient that allow us to make an impact.
Okay, no, I appreciate that, Michael. So when we think about resources that can support an individual in their home, one of the important factors is whether or not there's a caregiver available. How do you think about the science and availability of caregivers, and maybe even how you help the caregiver?
Yeah, the caregiver is really the key customer in almost anything that we're building. And so if it doesn't work for the caregiver, the model's probably not going to provide much value. Like these are at their heart support tools. So one of the factors that we look at, for example, is looking at caregiver density and performance in an area. So if you have two members in different areas that have the exact same patient picture, the individual components are all the same, how their community factors are the same, how they react in those community factors are the same, their diagnosis and clinical factors are the same, but so they should, in theory, have the same risks and outcomes. But if one is in a rural area that happens to only have one home health agency that is a lower performing agency, that their outcomes are going to be worse than one that happens to live in Florida, where there are more home health agencies than Starbucks, and they get a ton of membership and a ton of experience and are well performing. That the provider density and performance are clearly going to impact outcomes. And density is because it's going to increase the odds that a patient will be able to get staffed quickly, and we know how critical it is to make sure the patients are getting their care right away. So even in busy times, if there are a bunch of providers and they're skilled and talented, we'll be able to get people in there quickly. And if you're in a rural area, we want to look at what's the breadth of support and how effective have the facilities been versus the acute settings versus the home health agencies. So that ends up guiding where we can put patients and where they'll recover, even when every other component of the patient is the same. And so I think your question has two parts. So one is we do need to look at the complex universe of where that patient's going to be discharged, and then which will result in different recommendations and decisions. And two, we want to make sure that we are pulling all of these data sources together and creating a picture of the patient that we can give to the caregiver to allow them to make sure that the right gaps are being closed. Our thesis is that nearly every patient can recover at home effectively if we're addressing the right gaps. And what we're trying to do from an AI perspective and a data perspective is help identify those gaps so that we're preparing the caregiver with the tools and questions that they need to be as effective as possible.
Yeah, so thanks, Michael. And I appreciate the comment you made on the building this picture of the patient, right? So we have all this data available to us. We can build the pictures of the patients. We can build the pictures of the caregivers. We can proactively identify gaps. But now we need to take that information and make sure we're truly putting it into action, right? Eric, you've spent your entire career working through and thinking about how do we put these insights into action and really improve patient care. would love to get your perspectives in terms of what it means to think about treating an individual as a whole patient, and some of the best practices you've seen in managing patient care in a home setting and otherwise, and how you think about leveraging this picture of the patient driven by AI as part of the process to make it more effective. But before jumping into the question, which was long, would love for you to give an introduction of yourself.
Oh, thanks, Steve. You teed that up beautifully. And so I'm Eric Coleman. I'm trained clinically as a geriatrician. I direct the National Care Transitions Program, and I'm pleased to be a strategic advisor to CareCentrix. Well, for the purpose of this discussion, we can define whole person care as coordinating health, behavioral health, as well as social services in a patient-centered manner. And the goal is to improve beneficiary health and well-being, and ideally use our resources more efficiently and effectively. So my contribution really picks up where we have a patient, for example, ready for discharge, and we're really ready to deploy services in the home. And really building on what Michael shared with us, we have an opportunity to refine and complement the intelligent insights. But to do this by gathering direct patient family information, so we can have timely and accurate, actionable data and create a really much more robust plan of care. So just coming back, Michael referred to a scenario with two illustrative cases, patient one and patient two, and I'm just going to expand this a little bit further. So we'll say patient one is an 82-year-old woman, takes multiple medications for her diabetes, her heart disease, her chronic kidney disease. She happens to live in a community that has high associated risk for food and financial security. But the intelligent insights helped us, however, identify that the patient lives with two adults, and living nearby, she has both a son as well as a daughter, and the daughter happens to be a physician. And so in this particular instance, although the community has a high prevalence of food and financial insecurity, this particular patient is not experiencing that. But there could also be another patient, patient two, who on the surface has a very similar profile. But in this case, patient two lives with a much older spouse, does not have a car, and is experiencing food insecurity. And so really the advantages of being able to drill down further and then begin complementing that with real-time data gathered through direct interaction. So when we go back to patient one, now that we have a clear picture of her support system, we determine that she can be discharged directly at home. And that's a really a sense of assurance that we're going in the right direction. We initiate coaching, we initiate monitoring for the patient and family in the home. We engage the son and the daughter in the patient's recovery. We build in or initiate feedback loops so that physicians and health plans and care managers are all brought up to speed and are part of this plan that's moving forward. And so getting the patient on a successful track to recover and remain home. And so the main point here is, if you look at two patients side by side at the community, they might look the same in their social determinants of health, but when you drill down into individual, you get greater insights that will potentially avoid delays and facilitate moving the plan of care forward. Well, now we have an opportunity to interact directly with the patient and family, learn more about their strengths and challenges, particularly in the home. And in the interest of time, this is not going to be a comprehensive discussion of data elements that comprise whole person care, but rather we're going to focus on three areas that are of high importance, yet some of them receive relatively little, sometimes almost no attention when we develop an action-oriented care plan. And namely, we're going to talk about family caregiver support, promoting self-care confidence, and eliciting from the patient and family what matters most to them. So let's return to gathering a great understanding of family members' ability. And it's really not just ability, but also willingness and availability to support that patient. We know that family caregiving contributions occur along more of a dynamic than a static dimension. Family members might get sick, they might go out of town, they might get burned out. And as such, we need to revisit this with some frequency. And of course, the time of hospital discharge would be a very natural time to do that. Different ways we can do this. We can just sort of talk and ask the patient and their family to paint a picture of a typical week. How are the care needs currently being met? Who's involved with the various tasks? What's their capacity? Alternatively, there are validated tools that attempt to gauge readiness and comfort in managing chronic conditions. And one of these tools is called the FCAT, Family Caregiver Activation and Transition Tool. The FCAT's designed to facilitate common understanding in those areas in which family caregivers might feel relatively comfortable, as well as those areas where family members would benefit from more instruction by healthcare professionals. Both sides really look at each other as being very busy and having a lot on their plates. And so this is really designed to create some efficiency. It takes less than 2 minutes to complete. It can be self-administered by the patient, or it can be administered by the professional. There's also another tool out there. Michael was speaking a little bit about the different roles family caregivers play. There's a tool out there called DCAF, where each letter of the tool stands for a different contribution family caregivers might be making. So if you're sort of talking about one particular area of a care plan and there are multiple family members making contributions, this really helps you in a more efficient way figure out who the go-to person is. So in this acronym DCAF, D is the direct care, person who's doing the hands-on day-to-day. E is a more emotional support. C is the person who's coordinating care with the outpatient pharmacy, with primary care, with the home care. A is advocacy, and F is financial support. And you're welcome to download either the FCAT tool or the DCAF tool free of charge by visiting caretransitions.org. So we probe further. We learned that the daughter is the go-to for medication refills and for managing the pill organizer. The son is the go-to for day-to-day self-care needs. And there happens to also be a neighbor involved who provides transportation to appointments. Let's go down a little further about treating the whole person. And at this point, it's what additional tools or practices do we need to achieve whole person care? And I would argue that I often overlook patients' degree of confidence and understanding in their role of self-care. Fortunately, John Wasson at Dartmouth has developed a single question tool that's part of the How's Your Health initiative. And patients are asked, how confident are you that you can control and manage most of your health problems? And then there's an accompanying graphic where there's a thermometer numbered 1 to 10 along a visual scale. And you can either give a number or you can point on that thermometer of where you are. And this tool, one of the beauties of it is it helps facilitate more longitudinal or repeated measures to see which direction the person's self-confidence is going in their care. And you can access this tool and others from a website, howsyourhealth, all one word, .org, howsyourhealth.org. And finally, I'd encourage organizations to probe each patient and their family caregivers for what matters most. This is a large national campaign with the John A. Hartford Foundation and the Institute for Healthcare Improvement. And in this context, we're striving to know and align each patient's specific health outcome goals and their care preferences, including end-of-life care. And Terry's really going to elaborate more on these points. But for those who'd like to learn more, there's a terrific website, the IHI Age-Friendly Health Systems website. So in my last 20 seconds, I'm just going to offer a bit of word of caution, having been down this road a number of times. When we're gathering information, including social determinants of health, there is I think we need to be diligent to avoid a scenario of, quote, Groundhog Day, unquote, where the same problem gets discovered over and over again, even though earlier it was determined it was actually not an active problem, or alternatively, it's one that the patient and family don't wish to engage or go there. And by bringing it up over and over again, we not only frustrate them, but they also begin to lose some confidence in us. So we need to be mindful and have a mechanism to document when something's already been probed and perhaps put to rest. With that, I'll turn things back over to Steve, and we'll look forward to hearing from Terry.
Yeah, no, thank you, Eric. I mean, as you're talking through the different surveys and then building on Michael's point, it's almost like a Picasso painting, right? Where any individual dot means nothing, and the further you get away and you can see the whole picture, the more the opportunity presents itself in managing the patient care, more generally. And I love the Groundhog Day concept. Yeah, the Groundhog Day concept too is super interesting, because you get to the point where, and you've used this term before, Eric. I mean, kind of this we exhaust the patient sometime with repetitive outreach and potentially the caregiver. And we need to find ways to make sure we're not only creating these actionable insights, but kind of cataloging what has worked and what hasn't worked, to avoid that Groundhog Day syndrome. So Terry, I mean, your expertise is largely in kind of palliative-based care and end-of-life care. We'd love for you to kind of continue to build on some of the concepts that Eric's put out there in thinking about how you can apply some of these scenarios to thinking about kind of end of life care, more generally.
So thank you. I love being part of this panel. It's been a great discussion so far. So by introduction, I'm Dr. Terry Maxwell. I am a nurse by background, and I'm the general manager and the chief clinical officer for the CareCentrix Palliative Division, also known as Turnkey Health. And we have a community-based or home-based palliative care program that's nurse and social worker driven. And so, we think a lot about using data. So we have a predictive algorithm that is specially designed to target and identify people who would benefit from our program. But we've also spent a lot of time in thinking about, once you've used data to target the program, what's the most appropriate clinical model that somebody can design that's actually going to achieve outcomes that are specific to the population for whom you're trying to improve, their quality of life. And for our clients, improve member experience, number one. And I think the other thing is that we have been able to show that we can also decrease the overall cost of care by better coordinating care, aligning care with patients and their families' goals of care, et cetera. So, as I listened to both Eric and Michael, especially as I was listening to Michael, I think it's the promise of data where we're getting these actionable insights that is an amazing new tool in our toolbox that when I started in my nursing career, I could never have imagined that we would have. So first and foremost, I completely appreciate the promise of that. However, I would say that there are still limitations. Understanding the ability for somebody to be able to walk, the degree to which they have social support right now is still mainly in the free text part of medical charts. I actually believe that Michael and his team are going to be able to mine that kind of free text data for keywords and other kinds of things. There's already exciting work to be able to start pulling some of that information in. But I can tell you some interesting stories about the importance of actually getting in the home. And that's where you really, the rubber meets the road, right? Where things aren't always what they seem. And I gave you a really quick example of a story that we had recently where there was a patient who was going in and out of the hospital with hyperglycemia. She was a type 1 diabetic. Every time the team in the hospital met with her and did discharge planning, she had good caregiver support. She actually had a lot of insight into how to manage her disease. She understood how to monitor her glucose, was actively doing so. She understood how to administer her insulin. It wasn't until a nurse from our team got into the home that they found that the insulin was sitting out on the kitchen counter. And for those who don't have a medical background or aren't experts in diabetes, insulin needs to be refrigerated. It needs to be kept cool in order to work. And what happened was that a refrigerator was broken. So I don't know where you're going to find a data point, and she was ashamed to admit that they were at a level of financial insecurity that they couldn't afford to get their refrigerator fixed or replaced. But until that was discovered and they got the community supports involved to be able to get the refrigerator fixed, we couldn't fix the hyperglycemia problem. So I think that's a kind of a good example of, when we're talking about and thinking about a more sort of connected ecosystem, as our slide here talks about or is illustrating, is that there's such an opportunity to think about it from what the community can bring and structuring and leveraging support throughout the entire community to better either understand what the patient and family experience is, but also to meet their needs better.
That's a great example, Terry. So all the data in the world and painting this picture of a patient, it doesn't get you anywhere if you can't actually sometimes communicate with and or put eyes on an individual in their home and kind of better understand their situation. And that kind of leads me back to the question we asked earlier of Michael, and trying to determine, how do you use the data to identify caregiver gaps? I mean, particularly in, I think, end-of-life care models and palliative-based care, the caregiver can be so critically important to managing kind of outcomes. And, I think for the caregiver, there's also a lot of stresses and strains as they're kind of working through some of the challenges with supporting a patient in their home. Would love to get your perspectives on kind of the role of the caregiver and how you've seen success in actually helping the caregiver begin to cope with what that they're experiencing on a day in and day out basis.
So I love the focus on the caregiver, because although they're so critical to the successful outcomes of most people who are sick, especially those who are seriously ill, they do tend to get overlooked. Their needs are not usually assessed, and Eric spoke to that. There's tools, there's ways to ask simple questions, but I can tell you, clinicians are really busy, and they're focusing on the patient, and they're focusing education and everything to the patient, and the caregivers are just sort of, I think, often sort of taken for granted, and people think, they don't need a lot of help and support. And what I can tell you is caregivers need tremendous amounts of help and support on all levels. It doesn't necessarily even matter. I'm thinking about Eric's case where, the one daughter was a physician. Well, if she's an OB/GYN physician, it doesn't mean she understands how to take care of her mother who has pancreatic cancer. She might have a network to be able to call and understand medical terminology and things, but I have seen extremely sophisticated, intelligent, well-networked people overwhelmed immediately when suddenly thrust into a caregiver situation. I got a call recently from a colleague who said, could you help my friend whose mother just went on hospice? And he was like, I thought hospice was going to have somebody there all the time, and she's really sick and she's dying and they're not going to be there the whole time. What do I do? I got a call yesterday from a good friend whose mom had a mini stroke and was getting ready to go back from where she was visiting in Seattle back home to Philadelphia. The husband's my friend's dad is a physician. Well, suddenly she was slumped over right when she was getting ready to leave at 6 a.m. in the morning, and they ended up having to, call 911 and have the mom go to the hospital. And so she was calling, everything kind of turned out okay later. She was partly calling because no one can quite figure out what's going on with her mom. But it set up this whole thing of long distance caregiving, recognizing that parents really can't manage independently in their apartment any longer. Fortunately, they have the means to be able to move into something that's going to be able to meet their needs and they can afford. But all too often, many of our patients have tremendous amounts of financial insecurity. They have huge issues related to health literacy. They have food insecurity. And interestingly, among our commercial population patients, so these are all seriously ill people, about 25% of them have major financial insecurity, meaning that they have identified themselves as somebody who don't know how they're going to make ends meet at the end of the month. So people have so many different kinds of needs out there. So again, I think one of the things is that we've found that social workers are incredibly critical to our program. I'll give you another great example of ways in which providing social support is so important to good outcomes. We start every team meeting every week with a story, and this was a story a week ago. So that's how common this is. I didn't have to figure out where to find stories. I just had to think of the ones that were most recent. So it's a woman who is 77. She has leukemia. Her husband died in 2019 of ALS. She was originally, she has lung cancer. And she was originally diagnosed in 2017, but her cancer recurred. She has an adult daughter who lives nearby with her husband, and the adult daughter's husband, or the son-in-law, has leukemia, and they have 3 adult children. And so right away, I'm hearing themes of loss. I'm hearing themes of sickness. And grief and a lot of burden. It ends up that the woman with the lung cancer, our patient, really was pretty much at peace with whatever was going to happen and was not all that eager to be that aggressive about her illness. She really wanted to focus on comfort. But her daughter was so, I think, sad at the thought of losing her mom, but also so overwhelmed with caregiving duties across the board, right? Taking care of kids. She's got a husband with an illness, and then her mom with a worsening illness, and a dad who was probably ill for quite some time and only died fairly recently. And so it was a combination of the nurse working with the mom, and then recognizing that the social worker really needed to reach out to the daughter. And it was through developing a real trusting relationship with the daughter that they were able to kind of get everyone together. They worked on advanced care planning together, which really facilitated a deeper understanding of what the mom's wishes were. In supporting the daughter, she was able to kind of deal with some of the anticipated grieving, and together, the mom ultimately opted to stop chemotherapy that didn't appear to be effective anyway, and together agreed that it would make sense to go into hospice. And with hospice care, the daughter was able to get additional care supports that helped to relieve some of the caregiver burden so that she could really focus on being a daughter during her mom's final, weeks and months.
That's a touching story, Terry. And again, I think we have all of these data points, and as you said, they give you another tool in the quiver, right? But in and of themselves, regardless of how you use the data to paint a picture, without the eyes on the patient, better understanding the situation on the ground, better understanding the last mile situation, I think it gets really difficult to close the loop on a care plan for any individual. Eric talks about the family members as being absolutely critical to the care in the home, and figuring out ways to engage them. Your story, I think, just build upon that, Terry. So thank you for that. So we have a couple minutes. What I'd love to do is go off script a bit and just do a quick lightning round for any last comments anybody has. Maybe a minute, 2 minutes each. So let's start with you, Michael. Any other kind of last thoughts or observations for the audience?
Yeah, I mean, I liked how the discussion went, because it's so true that we put together these, what we think are these wonderful, brilliant models that will support our clinicians, and then it turns out that there isn't a fridge in the home in your example, Terry. And you clearly need to think about a comprehensive program that is going to be able to do all of the groundwork you can up front to help our clinicians, but also incorporate ways to look beyond that, and Eric, to your point, avoid the Groundhog Day. One of the things that we are looking at from a caregiver perspective is how can we start leveraging analytics to develop a picture, not just of the patient, but of the caregivers in that patient's life. And so, typically it's patient-centered as it should be, but everything else is just a branch, as opposed to really trying to assess the caregivers that will be around and what type of help and support and engagement they're going to need to be effective. And so broadening, which isn't new from a clinical perspective, but is new from a data perspective. How can we shift our models to more effectively identify how we can better engage the caregivers in the homes?
Thank you, Michael. Eric, any last comments?
Yeah, I think this discussion has really raised this notion of be careful what you wish for. So we as clinicians have sort of adapted our workflow over many years, and a lot of that has been adapted around not having information and kind of as martyrs saying, well, I had to do what I had to do because I didn't have the information. As Terry points out, all of a sudden you present clinicians with more information that can then help drive action. But if you don't give them sort of additional time with the patient and family and additional resources, then we're sort of frustrating all parties. So I think that the smart approach is to really take these intelligent insights and look at sort of the start to finish and how we might need to adapt some of our workflows to really accommodate the fact that we know a lot more about patients as a result.
Yeah, no, that is so true in healthcare and in many other parts of the world. Terry, any last thoughts?
Yeah, I think about the needs of seriously ill people. That's a population that I deal with. But gosh, even when you think beyond that, and their family members and those who love them, the needs are so vast. So how can we use tools like the ones that Michael and his team are developing to help us stratify and at least be able to try to use those tools to focus our clinical models where they're going to be needed the most and can benefit the most, so that because we don't have endless resources, and Eric's kind of speaking to that as well. So yeah, they don't tell us everything, but once we get in the home and we start collecting data, and we do it in our program in a very structured way, the other piece is, what data are we collecting that we can feed back to Michael and his team to continue to strengthen the models? And so I think part of it is for data teams and clinicians to work together. As when we talk about a connected ecosystem, that's another connected ecosystem that we need. That it's got to be, continuing feedback loops. And I think when we do that effectively, that's when we're going to really, see the promise that all of this can bring to improving outcomes for people, which is clearly all of our goals.
Yeah, and I think, Terry, I 100% agree, and I think it's a great way to begin to wrap the conversation about thinking about connecting the data teams that are building these insights with the clinical and the care delivery teams, because I think only by working together can we truly harness the power of what's potential there. Only by working together and continuing to learn do we avoid the Groundhog Day that Eric was talking about earlier as well. And that we truly add the value and turn these insights into the superpower that they truly can be, again, when done right. So, with that, I'd like to thank the panelists and appreciate the questions that have come in during the course of the webinar. And everyone, have a fantastic day.